Our next speaker will be, is Dr. Sioban Keel. She is an associate professor here at the University of Washington, graduate of the University of Minnesota Medical School, where she also did her residency before coming to Seattle as a fellow. She has a keen interest in particularly red blood cell diseases and iron, but has become quite an expert in molecular analysis of potential inherited diseases, which, and that is important, I think, to emphasize, are always thought to present early in life. But there is good evidence now that even if you are 50 or 60 years old, you could still be diagnosed with a disease at that time, which goes back all the way to what may be an inherited disorder. So without stealing more of your time, Sioban, you proceed, please. Looking forward to your presentation.
All right, can everyone hear me okay? Dr. Deek, are you able to hear me okay?
I hear you very well.
Okay, great. So I'm delighted, everyone, to be here with you this morning. And I'll preface the talk by saying the vast majority of cases of MDS that happen in older individuals are not inherited disorders. There are disorders that happen as acquired events that happen in a person's lifetime. So I'm talking about a subset of MDS, both in adults, a smaller percentage, that is inherited, and alternatively, MDS can present in younger individuals. And we're beginning to appreciate that in those younger individuals, a larger percentage of them are caused by inherited reasons that a person developed cancer. So when we talk about these inherited MDS or leukemia predisposition syndromes, broadly, they fall into kind of three categories. We've long recognized classical inherited bone marrow failure syndromes, and those oftentimes present with other findings. And so these typically are diagnosed in pediatric patients. An example is Fanconi anemia. And there are also inherited predispositions that happen for blood cancers that may or may not present with other complications. Those are mutations in a number of genes that sometimes the individuals may have a long-standing history of slightly low blood counts before they develop MDS, or a bleeding diathesis, a bleeding complication before they develop MDS. And then I'd say the third broad category is we're now recognizing that a number of inherited cancer predispositions are not limited to a single type of cancer. So you all have likely heard of BRCA1 or BRCA2. Those BRCA1 gained a lot of notoriety with Angelina Jolie. But we're recognizing that what we used to kind of categorize as inherited risk for breast or ovarian cancer, that individuals in those families can also develop cancers like MDS. So why is there an interest, or why do we care about making these diagnoses? Well, there's a few reasons, and many of them, the direct reasons are they impact the patient's care. And so in individuals that have inherited risk for developing MDS, that develop MDS, it has big implications if that person were to go on to a stem cell transplant. So in that case, we typically prefer to find a sibling donor if that person is a match. And if there's an inherited reason that the family developed MDS, we obviously wouldn't want to select a donor that might also carry that same risk. It also, because some of these syndromes are, the individuals with these syndromes have risk of complications from chemotherapy or radiation therapy, it helps us in our decisions about what types of therapies to choose. Some of these syndromes can be associated with risks of other cancers other than MDS, and so we monitor them differently, either with screening exams or imaging. And then also there can be complications that have nothing to do with the blood. These are inherited syndromes, and so the genetic change that happens is present in the person's blood cells, but they're also present in the lung and in the liver. And some of these disorders can develop lung disease or liver disease, and we monitor for those. It obviously has implications on family members. And so many of the patients that I see them in the context of their whole family. And we do testing of family members to see if other individuals are affected. What I'd say is that we're no longer in the realm of research when we talk about inherited risk for MDS or blood cancers. These syndromes are now included in practice guidelines in many disease classifications. And so this is really something that's present in the clinic now. So let me just step back a little and make sure that we're all on the same page in terms of just genetics. And I saw in Dr. Scott's talk that you just heard, he took us through a little bit of cancer genomics, but I want to talk about how does a cell package its genetic information. And so when I talk about genetic information, what I'm saying is what are the instructions that that cell has that tells it everything it needs to do throughout its lifetime. And those instructions are contained within the cell's DNA. And the way that the cell, and let's kind of think of this as two settings. This could be a cell like a hematopoietic stem cell that divides, grows up into red cells, white cells, and platelets, or it could be a sperm or an egg. And so in the case of either of these cells, when that cell divides, it has to duplicate or replicate its DNA. And that DNA goes into the offspring cells. And the DNA is arranged, all of us have, in most of our cells, 23 pairs of chromosomes. You got half of those came from mom, half of those chromosomes came from dad. In the sperm or the egg, you have half that number. And on those chromosomes are a number of genes. Think of those as the instructions. And those instructions are written in an alphabet. That alphabet we call base pairs. There's 4 different base pairs. And that's the ABCs of the instructions that tell the cell what to do. And those those instructions could be, say, in a sperm or an egg cell, the traits that we pass on from parent to child, the hair color, eye color, or alternatively in a red cell or a platelet or a white cell, the instructions that tell that cell how to grow and do the things that it normally does. So mutations, those are anything that is a change in the sequence of the DNA. And so what I'm showing here is the base pairs in a gene. And let's say this is the normal ABCs of this particular gene, A, T, G, C, T. A mutation in that sequence would be a change from the normal or reference sequence, in this case an A to a G, that alters what the instructions are. The book no longer reads the same as it did before. And so the example, the kind of simple example of a point mutation here, where the A was changed to a G, is in one case, it tells you that I have a cat, and that sort of point mutation results in I have a rat, and that has obviously a different consequence. So I think many of you are aware of the testing that you've had on your blood or your bone marrow. And so some of this looks familiar, that you've seen this testing done on your own, on tissue that's been taken from you. So I gave the example first of point mutations as one type of mutation that we can see, the cat to the rat example. And there are different ways that we detect these different types of mutations. Point mutations are detected through something called sequencing in the lab. Alternatively, you can have mutations that affect the whole chromosome, and those could be big structural changes of the chromosomes, something called translocations. The example I give here is a translocation between the chromosome 1 and chromosome 7. And we're able to detect those types of changes either on a karyotype, where the lab grows up your cells and looks at the chromosomes, or a slightly more sophisticated test called a FISH. We also can see as another type of structural mutation, copy number changes in the chromosome. So rather than having a translocation between one part of a chromosome and another part of a chromosome, you can have a complete absence of a chromosome. So in that case, the cell only has one copy of chromosome 7. We call that monosomy 7. And there are other changes also that can be detected by both karyotype FISH and then another method that's emerging and used quite frequently called microarray. So let's get back to cancer genomics. That's really what I wanted to center this talk on. And so cancer is genetic. All cancer is genetic. It's due to changes in the genetics of the cells. But not all cancers are inherited or hereditary. And so when we approach this, we ask, where is the mutation? And so I'm going to introduce two ideas here that are kind of take-home points. One is the mutation an acquired mutation? Were you born with that mutation, or did it develop? Was it acquired during an individual's lifetime? And the word that you'll hear for acquired mutations is somatic. Those are interchangeable language. And those are changes in the DNA that occur in the cancer. In this case, I show an individual that has lung cancer. That mutation is present in the individual's lung cancer, and it can't be inherited. It can't be passed on to the offspring. Alternatively, mutations can be germline or inherited. Those words are used interchangeably. And in that case, the change is present in the egg or the sperm. And then if that egg or sperm is passed on to the child, all of the cells in the child, so here I'm showing that in the child being completely yellow, all the cells in the child will be affected by those inherited or germline mutations. So in MDS, we have cancer that's in the blood. And so that's where things get tricky in terms of our testing for these for mutations. If we're trying to discern, is this mutation an inherited or an acquired mutation, and we test the blood, we can't make that distinction very easily because the blood has both the cancer, the MDS, and it also carries with it the inherited genetic changes that a person was born with. And so in that setting, in order to distinguish whether a mutation is inherited or if that mutation is present in the cancer, we have to do one of two things. We're really actually one of three things. One, you could test the parents, or what we do more directly is we either test the individual's blood when they're in remission, when there's no longer any cancer in the blood, or if that's not possible or feasible, we test DNA from a tissue that doesn't have cancer. So in this setting, rather than taking a blood sample, we do a skin biopsy, grow that skin up, and then look to see, do we see any mutations in that skin? And that should be what we call a germline source, that doesn't contain the cancer-associated mutations. So let me kind of put this in the setting of an informative case so you understand, gosh, what does all this mean in terms of patients that come to the clinic? So this is an example. Let's say a 40-year-old woman comes to the clinic. She had a bone marrow transplant for leukemia, and she's now post-transplant. She tells you that she had a history of low platelets in the past. She thought she had something called immune thrombocytopenia, and her mother had died of AML. She comes to the genetics clinic, and because she's post-transplant, testing her blood isn't going to help because the DNA of her blood now is the donor's DNA. And so the genetics clinic does a skin biopsy, grows up the skin biopsy, and sends testing, a genetic panel, and finds a mutation in a gene called RUNX1. That's a gene that we know is associated with an inherited risk in families of developing leukemia. And thankfully, we test the sibling who was her donor, and that sibling was negative. And then let's say this person has a sister, and that sister maybe goes to another physician and has a diagnosis made of MDS and has testing on her MDS on a so-called, what I'll call somatic genetic testing panel. So that's a panel that was designed to detect not inherited mutations, but to detect changes that happen in the person's cancer, an MDS cancer. And that testing actually came back negative. And the reason that testing would come back negative is potentially it's not designed to pick up the mutations that are inherited type of mutations. And so that person then had an appropriate panel, a germline panel, that tested for the family mutation, and indeed it was positive, and family members could be tested and monitored. So I kind of offer this case as an example of two things that I think are important. One is that it matters when we're talking about patients that either have blood cancers or are post a hematopoietic stem cell transplant, what source of tissue we send for inherited genetic testing. Because the DNA in the case of, in this theoretical example, was the donor's DNA. It wasn't the patient's DNA. So you had to get a skin biopsy Or alternatively, if the patient had MDS in their blood, we wouldn't be able to distinguish an acquired mutation from an inherited mutation if we tested blood. And then the second point that I think this case highlights very well that's an important to realize is, I think it can get confusing for patients. I had genetic testing. I hear that very often. I had genetic testing done. Dr. Keel, does that mean I don't have any sort of inherited disorder? And not all genetic testing is the same. Sometimes that testing, it's typically what we do now is testing for a panel of genes, usually someplace around 20 to 50 genes simultaneously. But if that genetic testing wasn't designed with the specific question of saying, I want to identify inherited problems, it may not be appropriate testing to exclude that. It may be designed just to pick up acquired changes in the cancer, but not inherited changes. So to kind of give you an example of this, people, we've realized that in medicine now, and the introduction of acquired mutation testing of tumor samples, that's been in the clinic for a long time. And I suspect many of you have had that on your bone marrow or your blood. And so there have been a number of studies that have now gone back and asked, well, gosh, if you look at those somatic mutation testing of the tumor, and if you have access to that person's germline DNA, could we go back and say, in people, in this case, a study of 360 patients that had testing with the intent of asking what are the mutations in their tumor, how often did that actually pick up an inherited mutation that folks might not have realized unless they had gone back and said, let's now get a skin biopsy and say, gosh, is that mutation present as an inherited change in the individual? And this is just one example of a study that looked at that. And it identified that 12% of the mutations that were present in these 360 individuals were actually inherited changes and I list the genes where those mutations were. DDX41, GATA2, and TP53 are all genes associated with inherited MDS or leukemia risk. So, I also wanted to just step back and say, well, what is the cumulative risk of developing an MDS in some of these families? And so what I show here is data that came out of the National Institute of Health. They follow a big cohort of patients that have what are called classical inherited bone marrow failure syndromes. And I introduced this earlier. This is one of the types of inherited risks for developing MDS. And in these patients, patients with Diamond-Blackfan anemia, dyskeratosis congenita, Fanconi, or Schwachman, the cumulative incidence of MDS by age 50 varies across these different genetic disorders. It's pretty low in patients that have Diamond-Blackfan anemia. Only 5% of those individuals develop MDS by age 50, but it's quite high in patients that have Schwachman-Diamond syndrome. About 50% or 60% of those individuals will get MDS during their lifetime. How about some of the other disorders that I introduced? Well, there's 2 points I want to make. One is that we are beginning to understand that these inherited risks for developing MDS are enriched among young people that present with MDS. And I don't think that comes as any surprise. And so there have been kind of 2 large studies that showed in a cohort of pediatric and young adults that presented with MDS, 7% of those patients had mutations in a gene called GATA2. And if you looked at just the individuals that had an MDS that was characterized by a particular chromosome change in their cancer, something called monosomy 7, 37% of those individuals had an inherited GATA2 mutation. And the other syndrome that's emerging as accounting for a large percentage of pediatric MDS cases are mutations in 2 genes called SAMD9 and SAMD9L. That looks to be accounting for about 20% of pediatric MDS patients. And similar to GATA2, a change in chromosome 7 is a little hint of the possibility of an underlying inherited disorder in this pediatric or young adult population. So we've done a study, now this is a number of years ago, where we looked at our own institution and asked, gosh, among individuals that had been transplanted at our center in the past, before there was a broad recognition of these disorders, but in whom we had stored samples of DNA from these patients, what percentage of pediatric and young adults that were sent to our center, presumably with an acquired MDS that had a transplant, what percentage of them actually had an underlying inherited reason that they developed MDS? And that number was 12.7%. So about 10% of people had an inherited reason that they developed MDS. Again, this was in a younger patient population. But I don't want you to walk away from this thinking that this is only present in young patients, that patients, because we're recognizing that this also can present in individuals that are older that develop MDS. And so a syndrome that's been described fairly recently, kind of in the late 2000s, 2019 or so, are germline or inherited mutations in a gene called DDX41. And that seems to account for about 2.4% of adults that present with MDS. And in this setting, the average age of onset of the MDS is in the same age group that you would expect for an individual that acquires MDS in their 60s. So at our center, which patients are we considering testing for an inherited cause? And I would say this is an evolving field. These aren't all firmly established, and different centers are doing different approaches. But here we think of it, of course, in a patient that has a suggestive personal and/or family history. We also think about it broadly, independent of the family history or physical exam findings, when we have younger patients who present with marrow failure, MDS, or leukemia. We always test family members in known inherited predisposition families. We're thoughtful about potential sibling donors when we're caring for a family with a known inherited predisposition. And then I think the last one that comes up quite frequently is what I alluded to earlier, is we send a lot of somatic mutation testing or testing that we think is tumor testing, and we identify mutations in genes that are also associated with inherited risk. So in those patients that have potential inherited mutations found on testing cancer cells, we oftentimes go back and make sure that that mutation was not an inherited change. So when we think about how do we go about this, or how do we approach patients and families about seeking genetic testing, germline genetic testing, really a key component is involving our genetic counselors. And genetic counselors are a group of professionals who specialize in providing education and emotional support to patients about inherited conditions. And they're very thoughtful about how this information can impact patients and their family members. And their goal is to provide a clear and useful set of information and guidelines about the genetic risk factors in a way that helps individuals to have their own personalized decisions about cancer treatment, prevention, and early detection. So I would put this in the context of the decision, an individual's decision of whether or not to pursue germline genetic testing. That's a complicated decision. And we really try and make sure that we involve a genetic counselor. We talk about their individual risks, the implications to the family. And it's a process that requires a lot of conversations to make sure that we do what's right and what's optimal for each of the individuals that we see. So at our center, it's done across our pediatric and adult programs. So we've partnered with colleagues at Seattle Children's that see pediatric and young adult patients in these families, and they're cared for there. When they transition at about age 21 or so, they come to the Seattle Cancer Care Alliance, and we have kind of an analogous team on my side made up of a medical geneticist, a hematologist, a genetic counselor, and also a nurse that specialize in this. And we offer hematologic malignancy cancer assessment and genetic testing. We've helped individuals with their hematopoietic stem cell transplantation planning, surveillance care, and then cascade testing for family members. So I think in terms of concluding thoughts, what I'd leave you with is one, that the recognition of an underlying inherited predisposition to developing MDS, it matters, it guides therapy. And that secondly, the goals of identifying patients and individuals with this is really to try and help keep people healthy. I'll also be present for the Q&A session that happens later this afternoon. So I'm delighted to have joined you this morning.